Daratumumab works through multiple different mechanisms in multiple myeloma, and these are all activation of different immunological pathways as well as direct killing of the tumor cells by utilizing the immune system. So it is only natural that we would consider using an immunomodulatory drug in combination with daratumumab. And we already have learned in the context of elotuzumab that when you combine elotuzumab with lenalidomide, it works much better than when you use it as a single agent. So along the same lines, daratumumab has also been combined with lenalidomide, and there was some very interesting data that was presented at the ASH last year, where again a group of patients with relapsed myeloma, not as heavily pretreated as the ones who were getting the single agent daratumumab, but again with a median of couple lines of prior therapy. These patients were treated with a combination of daratumumab, lenalidomide and dexamethasone. What was interesting was that almost 80% of these patients had actually a response to the combination therapy, including almost a third of the patients who had a deep response, like a complete response. Now, this is not something that we typically see in patients with relapsed refractory multiple myeloma. Again, many of these patients who have had gone through a stem cell transplant in the past and have received other classes of drugs like proteasome inhibitors and other immunomodulatory drugs. So that combination clearly appears to have efficacy way beyond what we would have anticipated from either of those agents alone. So there is clear synergy in combining the two drugs. Of course, this is a single agent, of course it is a single arm trial, so it's difficult to make too many interpretations based on the data, but clearly provide some exciting and provocative data that then needs to be confirmed in phase 3 clinical trials. In fact, a phase 3 trial of daratumumab, lenalidomide and dexamethasone, comparing it to lenalidomide and dexamethasone in relapsed myeloma who have had 1 to 3 prior lines of therapy, completed accrual late last year, and hopefully we should be hearing the results of that trial by the end of this year. Daratumumab has also been combined with other myeloma therapies, especially the immunomodulatory drugs as well as the proteasome inhibitors. So there has been some early data combining daratumumab in combination with bortezomib and dexamethasone, and this has been tried both in the relapsed patient population as well as in the newly diagnosed myeloma population. The data at this time is fairly sparse in terms of the number of patients that have been treated, so it's difficult to say for sure how much the combination does compared to either of the drugs do. But what we have learned from these trials is, yes, it can be combined with bortezomib relatively safely without any unanticipated side effects, and we have seen responses in myeloma when this combination is used. How it fares in combination with lenalidomide or other combinations is difficult to address at this point.
Dr. Philippe Moreau presented very exciting data at the 2014 ASH meeting in which daratumumab was combined with a number of different platforms in multiple myeloma. Specifically, daratumumab was combined with melphalan prednisone bortezomib. It was combined with bortezomib thalidomide dexamethasone. It was also combined with bortezomib dexamethasone. And lastly, pomalidomide dexamethasone. The primary reason for pursuing the study was to establish the safety of combining daratumumab with these various myeloma platforms, both in the frontline setting as well as in the relapsed and relapsed refractory setting. And importantly, what they showed in that particular study is that daratumumab can readily be incorporated into a number of different varied myeloma platforms quite safely. So it did not significantly increase the hematologic toxicity that you would expect with the other agents. And importantly, it didn't make the other side effects of some of these things worse either. For example, the rates of neuropathy with bortezomib-based therapy was the same whether daratumumab was on board or not. So this study established the safety of combining daratumumab with these various regimens, which then spawned a number of different phase 3 studies that are currently ongoing. So for example, there's the MMY 3004 study, which is a phase 3 study looking at bortezomib and dexamethasone with or without daratumumab in relapsed multiple myeloma. There is a frontline phase 3 study that the IFM is currently undertaking looking at bortezomib, thalidomide, and dexamethasone with or without daratumumab in a transplant context. There's a phase 3 study looking at melphalan, bortezomib with or without daratumumab. Daratumumab is basically being combined with just about anything that you can think of in the context of phase 3 studies. Importantly, Dr. Chari and colleagues presented data at the 2015 ASH meeting, which was basically an expansion of the pomalidomide, dexamethasone, daratumumab patients on the study that I just talked about. So the rationale of combining daratumumab with an IMiD-based platform such as pomalidomide is that we know both lenalidomide and pomalidomide have immunomodulatory effects. Specifically, they both increase the number and activation of natural killer cells as well as activated T cells. So the thought is you can actually get synergistic myeloma cell kill by targeting the myeloma cells for destruction with the daratumumab and enhancing the branch of the immune system that's responsible for antibody-dependent cellular cytotoxicity and getting synergistic effect. So the pomalidomide, dexamethasone, daratumumab study was basically an expansion where 100 total patients were treated. Daratumumab was given at the same dose and schedule that I previously talked about. Pomalidomide was given on days 1 through 21 of the 28-day cycle at a 4 milligram dose, and the dexamethasone was given once weekly. And again, patients were treated until disease progression. And importantly, again, the side effect profile was quite good with the inclusion of daratumumab into the regimen. So the hematologic toxicity, for example, was what one would typically expect with pomalidomide and dexamethasone in this particular patient population. At the time of the ASH presentation, 75 patients of the 100 were evaluable for response, and there was a 71% response rate with the 3-drug regimen. And importantly, there was a 43% rate of what we call very good partial responses or better. In other words, 43% of patients had at least a 90% reduction in their monoclonal protein level with the particular therapy. So this is a very exciting regimen that we'll hopefully see more of moving forward. So you'll certainly see the infusion reactions that we discussed. So you'll see the daratumumab specific reactions, but it does not appear that daratumumab creates clinically significant increased other toxicities when combined with these other platforms. I think that we'll need to see the phase 3 readouts to really be able to assess that with absolute certainty. So for example, is there increased hematologic toxicity with the use of daratumumab when combined with these various different platforms? There may be, but I think, at least in early days, it does appear that it can be combined quite readily with other myeloma platforms. And I would say that daratumumab can be very safely administered to a frailer patient. And I would worry more about the other drugs than I would about the daratumumab in that particular context.